So moderating the panel with me today is going to be Leila Bengali, and Catherine will again be monitoring the Slido. And, you know, with the remarks that Dr. Hernandez had, I think that kind of sets the stage here for our discussion of what has been going on and kind of in the general public health realm. And what I want to do in the way that we're going to do this panel is I'm going to give a very brief introduction of each of the panelists in turn. They each are very distinguished in their careers and have a long bios, which is in your packet. And I urge you to read them, but we want to hear from the panelists and not me reading the bios. And then at the end of that, I have a question, a prompt for each so that they can talk about what they do, what their organization does, and direct that towards the prompt. And then we will have some general questions and take some questions from the audience. And we're going to run for about 45 minutes to 50 minutes. So let's just jump right in. And our first panelist, and these are sort of in random order, but it's Dr. Murray Ross. And Dr. Ross is Vice President, Kaiser Foundation Health Plan. And he leads the Kaiser Permanente Institute for Health Policy in Oakland, California. Before joining Kaiser Permanente in 2002, Dr. Ross was a policy advisor to the US Congress, first at the Congressional Budget Office, and later as the executive director of the Medicare Payment Advisory Commission. Dr. Ross earned his doctorate in economics from the University of Maryland at College Park and completed his undergraduate work in economics at Arizona State University. His institute seeks to shape public policy and private practice by sharing evidence and experience from Kaiser Permanente's operations through publications, expert roundtables, and conferences. Murray, before I turn it over to you for some comments, just to get us started, you've been involved with the rollout of the vaccine over Kaiser's kind of vast network. What have you learned, particularly about the choices and equity considerations that would change how future healthcare might be provided?
Well, thank you, Jerry, for having me. It's been a great conference as always, and a real challenge to follow Dr. Hernandez. Beginning, excuse me, a lot of pollen up here in the Bay Area. Beginning last summer, two colleagues and I began a project to understand the interdependencies of policy, science, logistics, prioritization, administration, and education around the vaccines. And we drew on the expertise of our colleagues around Kaiser Permanente, from the people who are running clinical trials to the infectious disease docs, to our national pharmacy, our P&T committees, and care delivery. And while that exercise was designed primarily to inform our internal audiences, it also gave us a crash course in the pandemic response, studying it sort of up close and live. And rather than speak to sort of very specifically about Kaiser Permanente's experience, because I think we're having a similar experience to a lot of the systems in dealing with this, but let me talk about sort of what I've observed for the rollout with the country. You know, from the 30,000 foot level, I think we mostly got things right. Taking advantage of some just remarkable scientific advances in the past 5 or 10 years, Operation Warp Speed de-risked the vaccine development process and accelerated what used to be sort of a 4 to 6 to 10 year process, whereas we went from sequencing the virus in December of 2019 to emergency use authorizations for 2 vaccines in December. That's 12 months, and that's remarkable. And we have, and Dr. Hernandez alluded to this, we now have 3 vaccines available for emergency use. And going in, the FDA had announced that, you know, it would approve, or at least it would, authorize vaccines that met at least a 50% efficacy threshold. The Moderna and the Pfizer vaccines came in at about 95%. The Janssen vaccine is a little bit less than that, depending on which outcome measure you look at. but by all measures, that's an amazing achievement. Despite the pressure, the FDA held to the science at the end of the day. On the equity side of things, the National Academy of Medicine task force provided a very thoughtful model of vaccine prioritization. But, you know, when we look at the rollout, as my public health colleagues always remind me, vaccines, no matter how effective they are, don't do any good on the shelf. They only work when they're in arms. So in practice, thinking about the rollout, and at the risk of you know, being a Monday morning quarterback, it's been bumpy, as any ambitious project is. I mean, think back to the early days of the Affordable Care Act, and you know, we were rolling on square tires there for a while. As I've looked at it, it appears there's, you know, been some overpromising on the supply chain. How many doses by what day? Whether that's due to you know, manufacturers having challenges ramping up or just literal overpromising, I don't know, but we're getting there. The collapse of the travel industry meant we didn't have a whole lot of airplanes in the air to fly vaccines across the country where we normally do. And then you look at things like snowstorms shutting down the FedEx and UPS hubs in Memphis and Nashville in middle of February. And then operationalizing prioritization has been really challenging. And you know, for everyone who lives in California, you watch all the different, you know, pivots that we've taken. We're in group 1B.3C. It's been, in some ways, that's sort of not unexpected. Whether it's, you know, classifying people by socioeconomic category or by occupation, you know, essential workers, frontline workers, people don't neatly fit into categories. You know, the example I use is, what do you do with the, you know, the accountant who works from home during the day, but then, you know, drives an Uber in the evening? Does that make him or her a transportation worker and a frontline person? Don't know. It's complicated. Also, people live in families and households. You know, they're not just individuals. So you could ask the question, should you know, a husband and wife make 2 trips to get a vaccine because he's over 65 and she's under 65? And I would also just note that while age is sort of the simplest category, even by itself, age doesn't ensure equity. Black populations, this is long studied in Medicare and Social Security, have, you know, lower life expectancies, and a 65-year-old cutoff is actually somewhat discriminatory. And then Dr. Hernandez, I think, alluded to this as well, but there's also the digital divide. So when all of your appointment systems are dependent on having, you know, smartphones and up-to-date technology and the ability to navigate that technology, that's a problem. But all that said, I'm pretty optimistic. Production is ramping up. We're all learning from our mistakes and moving forward. And I don't know which holiday to pick, whether it's Memorial Day or July 4th, but you know, pretty soon everybody who wants a vaccine is going to have had one. So let me pause there.
Thank you, Murray. Next panelist is Dr. Elaine Batchlor. And Dr. Batchlor is Chief Executive Officer of MLK Community Healthcare, a health system that includes state-of-the-art private safety net hospital, 3 clinics, the MLK Community Medical Group, community and population health programs, and a philanthropy foundation. Dr. Batchlor's innovative work to increase access for underserved populations has been recognized nationally, earning her membership in the prestigious National Academy of Medicine, an academy committed to advancing health science and accelerating health equity. In 2019, she was recognized as an Irvine Foundation California leader. Before assuming leadership of MLK Community Healthcare, Dr. Batchlor was Chief Medical Officer of LA Care Health Plan, the nation's largest public health plan, and served as Vice President of Finance, Organization, and Operations at the California Health Care Foundation. Early in her career, Dr. Batchlor served as Medical Director for the Los Angeles County Office of Managed Care and as a Chief Medical Officer for Prudential Healthcare. She has many honors and awards, and I would urge you to go and look at them. She holds a bachelor's degree from Harvard University, a master's of public health from the University of California, Los Angeles, a Bruin, and a doctorate of medicine from Case Western Reserve University, and is board certified in both internal medicine and rheumatology. And if that's not enough, she has twin college student sons who are now at home because colleges are closed to deal with. So welcome, Elaine. And let me ask you, while MLK Hospital is an innovative health system, with a very high use of healthcare technology, and one that increased the use of telehealth, which we heard about from Dr. Hernandez during this pandemic, I know that you're concerned that there remain important issues about equity and improving health and healthcare for underserved communities of color, and those are the communities that MLK particularly serves. So can you talk about the barriers and challenges and how, if at all, the COVID pandemic has affected these issues?
Sure, thank you, Jerry, and thank you for inviting me to be part of this conversation. So Sandra did a great job of talking in broad terms about the healthcare disparities that the pandemic made visible. And I think our community and our hospital is an example of those disparities writ large. So our hospital is located in South LA in communities of Watts and Compton. It's the location of the 1965 Watts riots, and our hospital is a grandchild of those riots. And we were really the epicenter of the most recent surge that we experienced in Los Angeles. So someone said we were the epicenter of the epicenter. I was surprised at a point during that surge to come upon data that showed how many COVID cases all of the hospitals in the region had. And I was shocked to see that my small community hospital was treating more COVID patients than hospitals that were 3 to 4 times larger than us in more affluent communities. We had just a huge number of COVID cases. And even before COVID hit, we saw the conditions that made that possible. So we've been open since 2015. And since then, what we've seen in our community is an epidemic of poorly treated chronic illness. So as a hospital, we are kind of the last stop for many people who have chronic illnesses. Our emergency department is one of the busiest emergency departments in the state because of a lack of infrastructure for healthcare in the community and this epidemic of chronic illness. We see patients who are at the end stages of what are preventable conditions. So diabetes is one of the conditions that makes people vulnerable to COVID, and that's epidemic in our community. 3 times more prevalent than in the rest of the state. Diabetes mortality that's 70% higher than the rest of the state. Diabetic amputations and wound care are the most frequent surgical procedures we do at our hospital, and this is all pre-COVID. So when COVID came along, our community was already set up to have COVID impacted disproportionately. So now that we've gotten through this surge, we're really shifting our focus back to how we can address these underlying disparities. And when Sandra talks about the impact of racism on healthcare and public health, and people talk about institutional racism and systemic racism, they're talking about communities like ours. And I think one of the really important things we need to do is move from the abstract discussion about racism to the very concrete drivers and causes of those disparities. And I will mention one at this point. The majority of our community is insured by Medicaid or uninsured. Medicaid in California pays very poorly for community-based care. Hospitals that see a lot of Medicaid patients receive supplemental funding so that they are financially sustainable. There aren't similar supplements for outpatient care. As a result, communities like ours are severely lacking in physicians, urgent care, retail clinics, almost all types of healthcare infrastructure, in addition to all the other social determinants of health. This is a very specific policy and a very specific cause of the systemic disparities that we see. And if we want to start to address them and reverse them, we are going to have to change those policies.
Thank you, Elaine. Our next panelist is Desiree Horst-Clement, and she is the Senior Director of Research and Innovation at UCLA Health and Co-Executive Director of UCLA Biodesign. She launched the UCLA Health Innovation Challenge, and prior to UCLA, she was an administrator at Fred Hutch and MSKCC and of multiple NIH-funded efforts, including the creation of a physical science oncology center and T32 training program for researchers at the intersection of computational medicine and cancer biology. She was named the 2015 Life Science Innovation Northwest Women to Watch by the Washington Biotechnology and Biomedical Association, and one of 15 Women to Watch by Disruptive Women in Healthcare, and many other awards. Again, I'm just really shortchanging the biography because we want to hear from Desiree. And let me ask, what we've heard, what changes have been happening with providers, and your work has been with innovators and producers of the inputs to this process. The supply chains we saw broken in the early part of 2020 and the huge demands of the pandemic have shown us to be less prepared than perhaps we previously thought. What are some of the ways that COVID disrupted the healthcare system, and how do you think that innovation, manufacturing adaptability, and time to execution have changed? And what do you think we can expect as we go forward?
Thank you, Jerry. And there's some friends here on the panel and some new folks to me. So I just want to thank you all for organizing this today and having such a wonderful group. I joined the organization 4 years ago, dual reporting to our president and CEO of our health system and to our dean of our medical school, always with the hope of translation. That was always my background, is identifying our technologies and our therapeutics that we want to bring to the world to help heal patients. And when I got to UCLA, the explosion of innovation and tech happening in our region and in Silicon Beach with 500 tech companies moving here, we really wanted to be at the intersection of medicine and tech. And on campus, the leaders of the business school, the School of Medicine, and the School of Engineering all wanted to set up a program with our health system. So we started UCLA Biodesign to bridge our clinical care providers, our engineers, and those really with business acumen. And we had just launched our first year of biodesign. So we had these very talented trainees that had come to campus and had been in their program perhaps half a year when COVID hit. And one of the best things that happened is that we learned their skill sets, and we had individuals who had both an MD, MBA, and an engineer, and an MBA, and getting a PhD all in one person. And so we figured out who had what skills. And when COVID hit, I was really more boots on the ground. I was responsible for several of our COVID task forces. And as you mentioned in your question, there was a true disruption to our supply chain. And every time we thought we were coming up with a solution, a new thing would happen. And on the entrepreneurial side, we learned to fail fast, but on the clinical side, that is not what they're used to, and for good reason. So we redeployed staff and created an agile network to be able to have all hands on to tackle everything that was happening. There was a shortage of PETG. The swabs that the nation had were running low. We didn't have enough PPE for our workers. But while everything was going wrong, we did a few things right. And those things were that our nurses, our doctors, and our staff really stayed to mission. And even though they had vulnerabilities in their personal lives with families, children, spouses, they were coming to work every day to care for our patients. Another thing that really went right is our leader of our health system never took a day off. It was 24/7. I'm sure it's the same way at MLK. She was there every day and really just led through her own dedication, I think really helped the organization to do the same. And while this was happening, we had to figure out how do we move quickly. Often in academia, we take too long because we're really interested in the individuals that want to contribute thoughts. But in COVID, we just had to take action. So we created a command center, a COVID task force. We had a clinical trial group that came together, and there were so many ideas coming forward, which was awesome, but we had to figure out how to prioritize and utilize very precious and sick patients. You know, if we needed to have specimens or whatever it was that we were going to do, we wanted to make sure that we were utilizing everything appropriately. A lot of us came together, we redeployed staff, and we were able to solve most of our major problems in real time, and often having to resolve them as a new problem came up. But I really want to thank the community. We had donors and patients and others providing us 3D printers, providing us PETG rolls, Apple, Pepsi, lots of people had resources that they were able to deploy to UCLA. And with everyone's help as a community, we were able to pull through it. We did learn, and moving forward, infectious disease is going to hit over and over again, and our supply chain is definitely shored up and expanded. That said, we don't know what the next thing is, but we are preparing and thinking there may be. So there is, you know, we've increased amount, for instance, our warehouses to store supplies, things like that. When you ask what can we expect going forward, I really do believe in this model of an integration between medicine, business, and engineering. I think it's needed. We used to always have the physician scientist, but now I'm really interested in the physician innovator. I think that our physician innovators were the people who shined during the pandemic to come up with a lot of the problems that required either engineering skills or really business and manufacturing and negotiation. In terms of where we're headed, I think as so much of us are starting to do, we're getting more and more responsibility for our own wellness. So with apps and with ways that we can monitor and participate in our personal responsibility of healthcare, I think that that's a trend that will stay and continue. I think we even see that with wearing masks, like how far does it go, our personal responsibility to wellness and to our communities. So I definitely think that that's really important. Early adoption of technology, obviously, is something we were already doing, but in telehealth, we were able to really expand. We went up to 500,000 cases right away from telehealth. And although we had figured out the billing, there wasn't wide adoption. So I think COVID, in a silver lining, got us to get all of our care providers and our mental health experts to get online and to meet patients where they are, and able to do that on a cell phone. So a cell phone, a computer, or anything, but I say a cell phone as the minimum amount of thing that you would need to interact with our physicians. I appreciated all the comments earlier, and really racism, institutional racism and systemic racism has all been heightened. For many of us who have been living it for a long time, it was already our work of passion, but as a nation and as a global nation, there's definitely a spotlight we've never had before, and it's paved the way for new positions. So UCLA Health is getting their first health equity, diversity, and inclusion officer. The David Geffen School of Medicine is as well, and adds the word justice to their title. And I think that this is a trend that should stay, and that because we're having people, resources, and money deployed to this area, I hope that we'll continue to see the academic research translate over to our clinical care and to new business decisions that make us more equitable with our community. And then lastly, I'd like to say my personal passion is really around precise diagnosis and precise treatment of patients. So as we advance, those are the areas that I think will help obviously save lives, also save money. So I really like to focus on molecular diagnosis and figuring out things like, I was really involved in some of our gene therapy and spaces like that I'd really like to see more coming over from clinical trial work into our hospital. And lastly, I'd like to just say that our health and wellness also should include our planet, and that really, as we look at who we are and what we want to be, we want to not only be healthy for ourselves, but our planet has to survive as well. So these are the things that I'm thinking about and trying to figure out how to integrate and bring back to our institution. Thank you so much for the time.
Thank you, Desert. And one of the comments that you made about how everyone was working 24/7, this conference was supposed to happen last March. And so we all know why it didn't happen last March. And it's only sort of a testament to where we are today that we're able to put on the conference and everyone's not working 24/7.
That's a great point. I remember having to say, I just couldn't, there was no more time for things like this. So I'm glad that we got to this place and that we're here gathered today.
Exactly. And that's a good segue to Dr. Leah Vriesman. Dr. Vriesman is a professor and executive director of executive programs in health policy and management in UCLA's Fielding School of Public Health. She leads the Executive Master of Public Health and the new online Master of Healthcare Administration. Dr. Vriesman teaches healthcare strategy, international health policy, and speaks often on health technology and innovation. She specializes in innovative leadership development for provider organizations and the pharmaceutical and biotechnology industry. She's also the co-director of the UCLA Center for Healthcare Management. She received her Ph.D. in medical sociology from UCLA and her MHA and MBA in strategy and finance from the University of Minnesota, Minneapolis, my alma mater. Leah, your work has been at the intersection of healthcare and education, which are both relatively conservative fields in the way in which business is conducted. Now, we've heard about changes that have occurred in the field of medicine, at least during this pandemic. Does this reflect back into fundamental changes from your perspective?
Thanks for the great question, and thank you all, both participants on this webinar, but also my esteemed colleagues on the panel. I feel very lucky to be with you all, as well as to have reignited this panel after a year, right? We all could take a breath. So yeah, the term disruptive innovation is really thrown around a lot. And I think a lot of times what people are really meaning is incremental innovation. We try things and we try to make changes to our business models or to the way we conduct business. And I've been thinking, while scrambling like crazy, when exactly a year ago, we were told by the university that we were going to have to pivot and go to remote courses and all of our remote learning instead of being on campus. And I've been thinking constantly about the fact that healthcare as an industry and education as an industry are really analogous, even more than the business environment that had to pivot and go remote. And let me tell you a little bit why that is, because the business going remote to go to your work, your office, has already been something that businesses have been trying, allowing their folks to do, and have been flexible and willing to try that. Both the healthcare and the education industry are just ancient, right? I mean, that education industry sort of is the same model for the last 500 years, where a very wise person stands on the platform and everyone comes to the room and takes notes and the rest. And healthcare has this very hierarchical perspective of, you're supposed to stop what you're doing, regardless of job, regardless of obligations, take time away from your work, drive to a place, wait in a waiting room. And it really takes a better part of a day. And that's just if you're taking care of yourself. And so both of these two institutions, both from a regulatory perspective for healthcare, as well as a traditional sense of how do we seek care, how do we seek education, just sort of didn't change. And everyone said it couldn't be done. I'll tell you, 10 years ago, as a working mom of 2 small kids, I specifically left my PPO insurance and looked for an organization that I could do things conveniently online. And so I actually chose Kaiser Permanente, because at that time they had the best portal. I don't want to call, and I still have to do this with Kaiser, but I wanted to just log in with a password and make my appointments for me, for my kids, for prevention, all of that. I still have to call sometimes, but I wanted to give all that up 10 years ago, and it's been fantastic. Whenever I am in a situation, when I think about the moms today and I think about them dropping out of the workforce and I think about the inconvenience factor, this is why disruption was going to be so necessary. So as a professor of strategy, I often ask my millennial students, I'm sort of Gen X, I've got a mom who's definitely past baby boomers at 88 years old, but my students have been millennial. And for the last 10 years, whenever I ask them to do an innovation or an innovative style project, their number one feature of that innovative idea is convenience. They just didn't understand why they would have to, in a healthcare environment, be robbed of their convenience. And yet we would always shrug our shoulders and say it wasn't possible. So I think what's happened with this true disruption is that no longer could the educational world say online isn't good enough. We would basically be contradicting our change to remote learning. We would be saying, well, we've been doing remote learning and it's not good enough. Well, that's not acceptable. We've had to do it and we've had to make it of high quality. Our telehealth is now acceptable. And in fact, it's beyond acceptable. It's necessary, and including not only the millennials or the Gen X's, but my 88-year-old mom has done telehealth visits now for the last year. So we can't say that those folks are not included and will always have to be in the old traditional model for the older generations as well. So what I'm challenging, I guess, from my perspective in this panel and from the viewpoint I'm taking today is that this digital transformation has disrupted old business models in a way that we can't actually put the horse back in the barn. It's out, and people are not going to be willing to go back to inconvenient business models. I think, Jerry, you said earlier, and I was listening about your talk about business travel. People do want to get together and network. There's no question about it. Education is great to get together and learn in groups. Healthcare is important to get to be seen and have hands put on you and things diagnosed. But we are now in a pivot where businesses are trying to figure out whether to bring employees back. And I think both healthcare and education are at this very pivotal time where we are completely under a digital transformation. And we're going to need to find a hybrid solution for what works for everybody. So I'll stop there. I'm happy to answer any questions about it, but I know it's what my students, me, and all the world around me is right now really trying to pivot and see what the next new business model looks like.
Yeah, I mean, I think that's interesting that, you know, the pandemic has accelerated a lot of things, and we don't have to wait until the millennials and Zs are in their 40s, 50s because of the necessity of the pandemic. And historically, that's what we've seen with pandemics. They are accelerators of change.
Yep. And the health tech industry for years has been saying, how do we get healthcare to change? You get these super smart technological innovators, and what they never understood is, why doesn't healthcare change? We have this great app, we have this great convenience thing, we have teledoc, we have all this stuff. And we traditionally would go, yeah, it doesn't really work with our payers, it doesn't really work with our business models. Well, that's gone now. We have to answer that question.
Yeah, and that is a great segue to our next panelist. Omkar Kulkarni is the first Chief Innovation Officer at Children's Hospital in Los Angeles. In his role, Omkar is responsible for fostering innovation across CHLA's clinical and research enterprises. Prior to joining CHLA, Omkar served as Executive Director of the Cedars-Sinai Accelerator, powered by Techstars. Omkar is also led the Performance Improvement Department at Cedars-Sinai for many years, and has experience in financial process redesign at New York's Presbyterian Hospital. He has a master's degree in public health and healthcare management from Columbia University, a bachelor's degree in business administration from George Washington University, And so turning to you, Omkar, we've been having discussions, but we haven't yet touched on pediatrics and the way in which the pandemic is influencing both the delivery of services and innovation and partnerships to serve children. Are you seeing sea changes in this part of the business of healthcare as well?
Thanks, Jerry. And it's actually been great listening to my fellow panelists here. And I'm actually going to leverage some of their talking points to kind of talk about pediatrics as well. So as Leah just talked about, so the answer to your question is yes. I think pediatrics has absolutely been impacted. Everything from children not being able to be in a traditional learning environment to different elements of access to healthcare, which I'll talk about in a second. But kind of going in order, I think to Leah's point, I think education has been transformed, and especially K through 12 education or even early childhood education has been forced to be transformed over the last 12 months. And that has an impact in healthcare, in the health and well-being of these kids. We've been reading about the impact, and we'll learn in probably years and decades the long-term social impact that the pandemic has caused to kids of various ages. But when we're talking about pediatric care delivery, we've partnered with, I think you asked about partnerships, we've partnered with school districts across the city and the county throughout phases of the pandemic, early on, to provide coaching and training and education around how to best talk to families about the dangers of the virus, and then to further into supporting testing strategies, drive-through testing, various elements of PCR testing required to make sure teachers and students are safe. And then now, as we get into school reopening, again, working with school districts around how, how they're thinking about vaccinating their teachers, how they're thinking about ensuring that their school environments are safe. Some schools are doing various elements of testing. And so we, as in the pediatric community, both CHLA as well as the pediatricians that are part of our organization, and I think this probably applies across the country, are partnering with schools, because one of the core elements of a child's life is school. That's their center point. And until that returns to some element of, I don't know if normalcy is the right word, but until it achieves its goals to its fullest, kids can't particularly be healthy in a complete way. So that's what we've been working on. The other piece, as was mentioned by various folks, is around the digital transformation that has been forced to happen. We're very similar to that. We did about 100 telehealth visits in the year preceding March 2020. And in the last 12 months, we've done over 100,000. So, a very large uptick in using technology to engage with our patients and families, largely because we had to. I agree, you can't put the genie back in the bottle, but I will argue that as we look at our data, there's a sizable digital divide, as we've talked about earlier. Our patients, as Dr. Batchlor mentioned, similarly, we're 60 to 70% Medicaid as well. So we have patients that have a variety of social and economic challenges, SDOH issues as well, that prevent them from having the ability to access the healthcare that they need. And as we dig into who is accessing these digital resources, more and more we find that there is a discrepancy along language, along race, ethnicity, and other demographic factors that we need to address. Otherwise, we're not really going to have an equitable, we're going to further the inequities that exist in our community because of the tools that we're offering to patients. So bridging that digital divide and all the different fissures that it's exposed is a really important priority for us as we look forward. So schools is one, the digital divide is the second. The third I'll finish with is what Desert talked about. We're also partnering quite a bit with innovators, startup companies, early stage solutions that are focused on pediatrics. There's not very many of them. If you look over the last 5 years, there's been billions of dollars pumped into healthcare technology and innovation. Less than 1% of that amount has gone towards pediatrics, both on the digital software side as well as the medical device side. And so we need to find ways to not only encourage innovation, but encourage funding, encourage the rapid, ability to facilitate that innovation into our healthcare systems. We've stood up an accelerator program that actually has partners across the world. We have about 50 children's hospitals from the United States and Canada and Europe that are part of our program. And our goal is to speed up the innovation that occurs specifically in pediatrics.
Thank you, Omkar. So in our forecast, and when you listen to our forecast, it's actually fairly optimistic with the assumption that the pandemic, gradually through this year fades away as a factor in the economy. But if you look at our forecast by sector and think about inequality, it's actually very pessimistic that inequality is going to get worse because the sectors that are low-income sectors are the ones that were disproportionately hit by this pandemic. So going forward with inequality getting worse and the comments that you all have made as your introductory comments, there's been a lot of talk of economic justice, and part of that expanding healthcare, expanding Medicare and Medicaid or other medical insurance programs to everyone, so everyone has access to this. So I'd like to kind of throw out for the entire group, what's the feasibility of this? What technologies do we need to make sure that it happens? What kind of other interventions might we need to do in our communities to make sure that this expansion happens? And of course, the expansion to those who don't have access to healthcare is to just the communities that you all have been talking about, the underserved communities. So let's open that up and have a discussion on that as a kind of general question. Who would like to go first?
Well, I'll take a stab at it. First, just on the feasibility question, I would just direct people's attention to a report that came out right before the pandemic from the National Academy of Social Insurance. And it was an expert panel looking at various options to expand Medicare, whether it was Medicare for all, Medicare kind of public option, or just changing the Medicare eligibility age. And I guess I'd make 3 comments there. One is I was part of that panel, and the amazing complexity of trying to think through some of these things, from benefit design to financing to eligibility to phase-ins, it is a non-trivial task to do. Second, most people who have talked about sort of expanding Medicare continue to think of it as, let's expand the fee-for-service program and make that available everywhere. And to Leah's point, and I'm obviously biased here, it seems to me it makes more sense to think about options to expand that give people access to comprehensive care in integrated and data-informed systems. And then third is just, again, not every proposal and not all of them have details, but a lot of proposals to use Medicare as a way of reducing overall health spending. It's hard to think through how the existing healthcare system survives at Medicare payment rates throughout. It's not to say there isn't plenty of waste and inefficiency in the system, but the question is whether that's the way to address it.
Dr. Batchlor?
Sure. So I think that the confluence of the COVID pandemic, the social justice movement, the change in our federal administration, hopefully brings new opportunities to make progress both in expanding coverage and in improving quality and access to care. So we've made some good strides in expanding coverage through the Affordable Care Act, in expanding Medicaid eligibility and making insurance exchanges available to people. But we haven't made sufficient progress in translating that into quality and access. And we still have communities like our community in South LA that is a healthcare desert, where there's a lack of healthcare infrastructure. And even though people have insurance, they don't have places to go to get the care that they need. So I think that we need to make progress on both of those fronts. Hopefully people have a bigger appetite for funding some of these changes than they had before COVID. Many people have lost their jobs. They've seen that the connection between employment and good health care can be tenuous, and that we need a stronger safety net and better investment in programs like Medicare for all. So, I'm hopeful that we will have some of that progress occur in the next couple of years. But it probably will require us to shift resources and priorities from some areas to other areas.
And I know, Omkar, you're going to have to leave us a little bit early, so let me give you the opportunity for some comments.
Sure. So what I would say is we've seen various policy changes, or actually more just the relaxation of the enforcement of certain policies over the last 12 months through waivers and through various elements of the public health emergency. As we think about consumer preferences around things like telehealth and remote care and different ways of increasing access for various communities, there will need to be legislation that makes these various elements permanent. Otherwise, the natural element is to revert to the previous world in terms of the way in which services were reimbursed. It's especially challenging for organizations that are heavily Medicaid reliant, like I think MLK and us, because we've got everything is various at the state level. So it's not necessarily something that can be necessarily legislated at a federal level. But I think those are key elements around what we need. And specifically within the Medicaid system, I think there could be reforms around remote patient monitoring, other elements of leveraging digital technology, even elements around social determinants of health and how various services could be reimbursed. I think there's been innovation in that space. I think pre-pandemic, there's been quite a bit that's been promoted during the last 12 months. I'm just hopeful that over the next few years, we see that continue. I think Dr. Batchlor's point about the momentum for that is strong. I think we all just need to keep pushing for it, even after we've all had our vaccines and things are opened up again and things revert to quote normal.
Thank you. And I think we're going to run just a couple of minutes late because this is such an interesting and important panel. I think Leila has a question, and then Catherine has a question or two from the audience. So Leila, ask away.
Excellent. So I want to tie some of the changes in healthcare and the healthcare industry that we've been talking about to the economy and to employment. And we've been discussing a number of changes in the healthcare industry. So I want to ask the panelists, how have recent changes in the industry affected the types of skills that are needed to work in this industry? What new jobs are there in the industry now that didn't exist 5 years ago or 10 years ago?
So I'll just jump in really quick with that one. This is something that I think about all the time, as do my colleagues, when we're thinking about training the incoming workforce that's on the younger side with their masters. And then with my executive education program, those returning who may have 10, 15, 20 years of experience returning for a professional master's degree. And, we have to listen to the employers and to this new world very closely as to what they need. One of the things that we've really been increasing is our data analytics skills. And again, this is a master's in public health, so these are not people who are going to be data scientists per se, but they have to be able to understand how to ask for data. When they look at these huge pools of data, they need to understand how to analyze that data, whether it be statistically, whether it be financially. And then finally, we're teaching them data visualization skills, because the data is so great. Just looking at pages and pages of a spreadsheet isn't okay or enough anymore. So we're teaching Tableau. We're teaching various skills that really are going to make a 21st century healthcare manager, administrator, clinician manager. So we're really focusing on not only the traditional management skills, but also the increased need for data analytics and visualization.
One thing I would say is that we need more people who are able to work at the interface between technology and healthcare delivery. So I think that we've seen the emergence of a lot of technology tools that are not well aligned with the processes of care. And electronic health records are one example. They've got a lot of promise, but they've also led to very significant provider burnout. And we need people who have both the ability to innovate and develop new tools, but also have an understanding of how those tools can be used productively in care delivery.
Those are great points. I'll add another, which is clinical genetics. So there are not enough clinical genetics folks graduating every year to even fill the open spots that we have across the country. As I mentioned earlier, as we get into precision medicine and precise diagnosis and treatment, we need people who can talk to patients and have them understand the process. And UCLA, with the help of Clara Lajean-Cher, one of our people in the School of Medicine, has designed and opened our first cohort to graduate with a new master's in clinical genetics. So this space is big. We're being approached by a lot of startups with telegenetics. And I just think the space of genetics is going to be huge. And as you mentioned, wasn't really there so much 5 years ago.
Yeah, that's a great point. Taking new technology and moving it from opaque to something that the general public can understand is a big issue, right? And that was something that Dr. Hernandez was talking about. I think, we are running late. I want to take at least one question from the audience. So let's do our last question. And Catherine, what is the most burning question from the audience?
So I think I'll bring up this one because many of the panelists talked about telehealth, and this is a question about telehealth adoption. Many of you spoke about how it was forced upon you kind of throughout the pandemic. This question is about how much you see that persisting after the pandemic when in-person services are able to be rendered much more easily. Do you see telehealth continuing in all of the areas that you serve, or do you think it'll return to in-person for specific services or specialties?
I'll just say quickly so others can weigh in. Our explosion is waning slightly with the safety that people are feeling about coming back in. However, I believe that telehealth is here to stay. I like your students. I am all about convenience, and I myself want access to a doctor, but I don't necessarily want to see that doctor unless I need to. So I think, for those of us as we're coming up, the next generation, we definitely want it. But I think for certain things, it's definitely going to stay and has made it more easier, especially mental health. So to be able to get some of those services online and to take away the stigmas and associations of physically having people know where you're going when you're entering some of those spaces that you consider private. I think, a lot of students, a lot of young people are taking advantage of these opportunities, and I'd like to see them here to stay. I think there's great spaces for it in terms of female health and just other areas where you want access to a doctor right away, but you may have some reasons why, or sensitivities or embarrassment about going in. So I want to advocate for us to keep it and for companies and startups to keep thinking about how to advance it into a way that's very easy. And with that said, and because there was a comment in the notes, everyone does not have a computer. And I'd really like to also see a movement about smartphones getting into people's households, in particular, think about Indigenous people and people that are very remote, how important telemedicine is for the care of those really at our greatest need. And I think in 2019, we were at about 81% having cell phones, but not all smartphones. So we have a lot of work to do to make this accessible to the communities I feel are most disadvantaged and need it.
I agree with that. And a couple of things I'd add is that we had tremendous uptake of telemedicine in our community. So most of the people who live in our community have smartphones and are able to participate in telemedicine, and actually also found it more convenient and more accessible. One thing we saw was the no-show rate for appointments drop from near 50% for in-person appointments to below 7% for telemedicine appointments. I think it would be great for us to be able to continue to provide this kind of access but the financial incentives are not aligned. You know, providers don't make as much money from doing telemedicine visits. And in a Medicaid environment, providers are already struggling with very low reimbursement. And I think that when the financial incentives are not aligned, you know, we don't always get the behavior that we would like to see. So I think that's a continuing challenge for telemedicine.
And I just mentioned also that we were able to deploy an equipment-assisted simultaneous translation happening for our Spanish-speaking populations and pediatric patients during this time of COVID. And the translation being real time, only a 5-second delay, rather than calling someone, having someone translate, it really helped. And as just mentioned, same thing for surgeries. We dropped down to no cancellations for a period of time because they were able to do their pre-surgical the day before and relieve some of the fear about coming in. So I just want to say that there are awesome opportunities with telehealth for translation as well that we aren't able to do in person.
So I wish we had another hour. There's such a wealth of expertise here and so many questions that we all have to discuss. One thing that occurred to me, Desiree, when you were talking, was rural healthcare, and in particular the way in which this pandemic hit the Navajo Nation. And I drive through there every year on the way to Colorado, and there's no cell service. So even if they did have smartphones, telehealth is not going to work until you build up the infrastructure, right?
That's correct. Yeah, we were able to shore up the Navajo Nation supply of PPE 3 times during the pandemic. I also sent it to the Oglala Lakota people, the Pine Ridge Indian Reservation, and the Apache. So I'm very interested and connected and concerned with our rural patients as well. But you are right, there is no cell service. But on the flip side, for those that have phobias of things like 5G and things like that, there's a lot of nature. So we have to figure out, there's a balance that will have to occur as we think about populations that do want to live a certain way and figuring out how to deliver care respectfully.
So to close out the panel, I just want to mention that 2 years ago, I was moderator 3 years ago, I was moderator on a panel about healthcare technology. And the last question that I asked was, when is technology going to disrupt the healthcare industry? And my panel was between 20 and 40 years. And then they said, you're the moderator, tell us. And I said, it's going to be within 10 years. I didn't know a pandemic was coming, but it looks like I was right. And on that, I really appreciate each of you taking the time out of your schedules, coming and sharing your knowledge and insights with us. This has been a great panel. So thank you very, very much. And this will conclude our conference. A big applause for all of you. Really, this has been great.